Hi guys, so today we are talking about diuretics. So I've included this in the CVS pharmacology series because in our lectures we mainly talked about using diuretics as antihypertensive treatments and treatment for heart failure, but this could also be included in renal pharmacology because diuretics they ultimately act on the kidneys. Okay, so there are five main types of diuretics, and we kind of classify them in uh, in multiple ways. So the five different types include thiazide diuretics, loop diuretics, potassium sparing diuretics, carbonic anhydrase inhibitors, and osmotic diuretics. So we can classify them based on their site of action. So thiazides, they act on the distal convoluted tubule. The loop diuretics, they act on the ascending loop of Henle. The potassium-sparing diuretics, they act mainly on the collecting duct, but also in the late part of the distal convoluted tubule. Carbonic anhydrase inhibitors mainly act on the proximal convoluted tubule, and osmotic diuretics, they act in multiple locations in the proximal convoluted tubule, the distal, not the distal, sorry, the descending loop of Henle, and the collecting duct. So basically, in parts of the nephron where it has high water permeability. So I have a picture of the nephron here just to, remind you guys where these locations are. So here we have the Bowman's capsule, followed by the proximal convoluted tubule, and then the nephron goes down into this bit called the descending loop of Henle, and then obviously goes back up. This is the ascending loop of Henle, and then here we have the distal convoluted tubule, and then eventually the collecting duct. So I hope you can all appreciate that there's this line here. So here at the top, it's part of the renal cortex, so the outer part of the kidney, and here at the bottom we have the renal medulla. So the difference between these two is basically just the osmolarity. So in the renal cortex, it's less salty. It's about, I think, if I'm not mistaken, 300 milliosmoles, and here it's more salty. The medulla is saltier, which means it has more solutes dissolved in it. I think it's about 1000 milliosmoles. I'm not sure about the figures, but just remember that there's this gradient between the two regions of the kidney. We can also classify diuretics based on their efficacy. So how good are they in excretion of water, in excreting water? So thiazide diuretics, they're medium ceiling diuretics. They're not the most powerful ones. So the most powerful, the most potent diuretics are loop diuretics, and then and osmotic diuretics as well. And then the low ceiling diuretics are the potassium sparing diuretics and the carbonic anhydrase inhibitors. And I just want to define two main words so you're not confused. So diuresis is the excretion of water in the form of urine, and we have this other term called natriuresis, which is the excretion of sodium along with water, because some of these diuretics, they just promote the excretion of water, which is just diuresis, but most of them, they promote the excretion of both water and sodium. So common examples, so thiazides, we have hydrochlorothiazide. Loop diuretics, we have furosemide. I've just taken like the most common ones, but we'll have more examples later. Potassium sparing diuretics, we have spironolactone. Carbonic anhydrase inhibitors, we have acetazolamide. And osmotic diuretics, we have mannitol. Alright, so let's start with thiazides. As we've mentioned from the previous slide, these class of drugs, they act on the distal convoluted tubule, so here. And in this region, from physiology, hopefully we can remember that about 5 to 10% of our sodium, total sodium, is reabsorbed in this region. Thiazides are only active via the oral route. Common examples include hydrochlorothiazides, chlorothiazide, and we have thiazide-like diuretics like chlorthalidone and methalazone. Chlorothiazide, I think, is the only thiazide that's available for the parenteral route. The others are oral. And chlorthalidone has a longer acting, is longer acting than hydrochlorothiazide. So mechanism of action, we'll talk more about this in the next slide. Basically, thiazides, they block the sodium chloride co-transporter, and by blocking this, we get moderate diuresis, so moderate amounts of water loss through the urine. And we also get increased reabsorption of calcium, which can lead to hypercalcemia. Again, we'll talk more about this in the next slide. Alright guys, so now let's discuss the mechanism of action of thiazide diuretics. So here in blue is the membrane of the lumen of the early part of the DCT. And this other blue line here kind of signifies the end of the early part of the DCT. It means that we're kind of going to the late part of the DCT towards the collecting duct, so more downstream, okay? So in green we have our cells, where there are, different types of co-transporters, symporters, and transporters of different ions. And here in pink we have our peritubular capillary. In between the cells and the peritubular capillary we have the interstitium. So here is the apical membrane. So apical membrane or luminal membrane is the membrane of the cell that's orientated towards the tubule, okay? And the basalateral membrane is the membrane that's orientated towards the capillary. Okay, so I hope that's clear for now. So what happens? So here I hope you could recognize our little guy here. This is our sodium-potassium, sodium-potassium ATPase, which is very active. It transports sodium out of the cell for the exchange of potassium back into the cell. So, to be specific, 3 sodium out, 2 potassium back in, right? So if you think about it, if this process keeps happening, then we're gonna decrease the concentration of sodium inside the cell. So where does our cell get this sodium from? Where does it, how does it pick up extra sodium to be transported out? So the cell gets this from 2 main places. So the first place is obviously from our lumen, from our tubule, because the filtrate is rich in sodium at this stage. So sodium is transported in alongside with chloride, through this sodium chloride co-transporter. So sodium and chloride goes in, and the cell's happy again because the sodium stores are filled. It could also get it from this sodium calcium antiporter, which draws sodium from the blood into the cell for the exchange of calcium from the cell into the blood. Right, so what I've described so far is the normal physiological condition. So now let's try, I don't know if this is going to work. Oh, okay, it works. So thiazide diuretics, they block this sodium chloride co-transporter on the apical membrane of the cell. So that means that, sodium and chloride cannot go into the cell anymore. So this inhibition of the sodium chloride co-transporter leads to a decrease in sodium inside the cell. And this low sodium inside the cell kind of increases the driving force for the transport of that sodium from the blood via this sodium calcium antiporter, because it has nowhere else to get it but from the blood, okay? And then this also leads to the decrease in calcium in the cell because, we're pumping loads of sodium back into the cell for the exchange of calcium. So that means that our cell is getting deficient in calcium here. So this decrease in the concentration of calcium inside the cell becomes the driving force for calcium reabsorption from the tubule, because the tubule is rich in calcium and other ions, right? And this tubule and this calcium is reabsorbed into the cell via this apical calcium selective channel. Okay, I don't actually know what it's called, but it's just a calcium channel in the apical membrane. Okay, and this leads to hypercalcemia because we're taking lots of calcium from the urine, from the filtrate into the cell, and reabsorbing that back into our bloodstream so that we could keep pumping sodium out. So here we build up the concentration of calcium, and here we decrease the concentration of calcium. Let me just write that down. So here there is a decrease in, sorry, I'm really bad at writing, decrease in the calcium, and here we increase the reabsorption of calcium. This is an important point because we have to know this to make comparisons with loop diuretics, which does the complete opposite basically. So this increase in reabsorption of calcium in our blood is actually quite good in improving bone density, so it's used for osteopenic patients. And it could also decrease the risk of forming calcium-containing kidney stones, for example. Right, so what other things happen? So now we move downstream into the late part of the collecting duct, towards the late part of the distal convoluted tubule, towards the collecting duct. So what do we have here? So here we have this passive exchange of sodium, protons, and potassium, right? So the sodium concentration drives this exchange. So we have lots of sodium here because we've just blocked our co-transporter. So here we have lots and lots of sodium, right? And as I said, the sodium concentration drives this exchange. So the high concentration of sodium in the lumen becomes the driving force for sodium to go into the cell from the tubule, okay? Making the luminal charge more negative. So obviously, because this is a positive charge, if it goes into the cell, this leaves like a negative charge there, okay? So this negative charge encourages positively charged ions to go into the lumen to kind of neutralize this charge. So the protons and the potassium ions, they go through these channels, and therefore are kind of lost in the urine, because we're in the collecting duct. We don't reabsorb anything anymore here. Anything that's left in here is lost in the urine. So we increase the loss of protons, and we increase the loss of our potassium ions. So the loss of hydrogen ions, obviously because it's acidic, it will lead to alkalosis, and the loss of potassium in the urine would lead to hypokalemia. Okay, so basically what is the net effect? So we lose hydrogen, which means that we go into metabolic alkalosis. We lose our potassium, which means that we go into hypokalemia, and then we decrease the calcium concentration in our urine, which means we are in a hypocalciuric state, and we increase the calcium reabsorption, which means that we get hypercalcemia. Okay, so let's continue discussing thiazide diuretics. So uses, it's actually a first-line antihypertensive treatment. It's one of the best initial treatments for hypertension, if not contraindicated, obviously. It can be used alone or in combination with other antihypertensive drugs. So the next one, treatment of mild to moderate heart failure, obviously to remove the edema. It could also be used for the treatment of calciuria, as I said in the previous slide, because we can take that calcium from the tubule and reabsorb it back into the bloodstream. So it could decrease the concentration of calcium in the urine and therefore treat hypercalciuria. It could also be used for treatment of recurrent calcium stones, or just reduce the risk of forming calcium-containing kidney stones. And before I go to this next point, I forgot to put here, it's also used to improve bone density for osteopenic patients, which I think I mentioned from the previous slide. And then this last point here, it's used for diabetes insipidus. It's used to decrease urine output in diabetes insipidus. So you might be thinking, why are we using a diuretic to reduce urine output? So in diabetes insipidus, thiazides have a paradoxical effect. So what is diabetes insipidus? So diabetes insipidus is characterized by the excess water loss, right? So that's called polyuria. And thiazide diuretics would further increase this urine loss initially, but would later promote water and salt reabsorption, which means that we could decrease the urine output in these patients. So now the adverse effects. So we obviously get electrolyte imbalances, we get hyponatremia, we lost some of the sodium into the urine, we get hypochloremia because we're not absorbing that chloride, remember, because we blocked the sodium chloride co-transporter. So sodium and chloride are just lost in the urine, so we don't have them in the body, so we become deficient in those electrolytes. We get hypercalcemia, as I've mentioned like many times, and we get hypokalemia because we lose, the potassium in that collecting duct, and we get alkalosis because we lose the hydrogen ions as well. We also get hyperuricemia. So hyperuricemia is, increased urea basically, and the reason for this is because the thiazides, they actually inhibit the organic anion transporter that transports uric acid from the bloodstream into the tubule. So the uric acid just kind of it just builds up in our body basically, which makes us more likely to get gout or exacerbate gout. Contraindications: we can't use thiazide diuretics if we have impaired or inadequate renal function. Alright, just to add to that, as I said about gout, so this is contraindicated for people with gouty arthritis, for example, and obviously we can't use this if someone is already hypercalcemic, because we're just gonna keep increasing their calcium in the body and we might end up killing them.